Kia ora. My name is Janos Jaiprasad Samuel. My student ID number is 300-23248, and we are doing study at Toyohama Institution, and our course is Infection Risk Management Level 7.
And my name is Xavier Zapanta, student ID number 300-28627. Me and Janus is going to discuss about central line associated bloodstream infections, or CLABSI.
What is CLABSI? A CLABSI is a serious infection when microbes enter into our bloodstream through central line. And central line is known as central venous device or central venous catheter. And this line can deliver medicine directly into the patient bloodstream. And it can also use to draw your blood, and sometimes it can be helpful to monitor the blood pressure in the ICU setup. And there are 4 types of central line. The first one is peripherally inserted central line, and the second one is subclavian line, and the third one is internal jugular line. The fourth one is femoral line. The first one is placed on our hand, the second one is subclavian line, which is near to our collarbone, and the third one is internal jugular line. Is it near to our internal jugular vein, and femoral line is placed on our groin region. And sometimes the patient who is staying more than 1 week, 2 weeks in the hospital, they can get easily infection. So prolonged use can cause serious bloodstream infection. And these are the 2 types of catheter. The first one is short-term central catheter. The second one is peripheral inserted catheter. There are 2 common microorganisms which cause CLABSI. The first one is Staphylococcus aureus, and the second one is Pseudomonas aeruginosa. The first one is a gram-positive cocci in cluster. It looks like a grape shape. And Staphylococcus aureus is a major bacterial infection which causes many kind of clinical manifestation. And Staphylococcus aureus is a type of germ which most people carry on their nose, and it's already available on our skin too. And when a patient get treatment through central line or any kind of catheter, the infection can spread easily. And Staphylococcus infection is higher for the patient who's in the intensive care unit. Usually in the hospital setup, ICU and emergency care, people they get easily infected through Staphylococcus aureus. And Pseudomonas aeruginosa commonly found in soil or water. In the hospital setup, it can be found on the medical equipment as well as on the walls. Pseudomonas is a multi-drug resistant. Pseudomonas is like it can find a new way to stop the antibiotic. So it's like antibiotic resistant, and the next time when they are using the antibiotic, it cannot be useful. And it can cause infection in the blood and lungs and other part of body after the surgery. And the post-operative care surgery infection is more in the Pseudomonas aeruginosa.
Independent risk factors for developing CLABSI. Risk factors are variables that increases a patient's risk for developing a certain infection. There are a lot of risk factors associated with CLABSI, but I'm going to discuss the important ones. So the duration of both the hospitalization and the catheterization is an important risk for CLABSI, because the longer the catheter is inserted inside a patient, the more chances for bacteria to invade this catheter site. Next, heavy microbial colonization in both the catheter hub and the insertion site is also a risk for CLABSI. The site of catheterization is important because femoral catheterization among adults would increase the risk. Femoral catheters are near the groin, which have heavy microbial contamination, and this would increase the risk for CLABSI. Neutropenia, or the decreased WBC count, would increase CLABSI because WBCs, or white blood cell, are battle infection, and the decreased number of WBC would increase the risk for CLABSI. Prematurity, reduced nurse-to-patient ratio. So in the ICU setting, there are 2 patients for 1 nurse, and in general wards, 5 patients to 1 nurse. When this ratio is not followed, it would be harder for nurses to give the optimal care to patients, thus increasing the chances for CLABSI. total parenteral nutrition, substandard catheter care or excessive manipulation of the catheter, and lastly, transfusion of blood products. Blood products contain additives which provide nutrition to blood components. While these additives would help blood components, they will also provide nutrition to the bacteria, thus increasing infection risk. I'm going to talk about the prevalence rates of CLABSI infections in New Zealand. In 2008, 4 major Auckland units reported 3 to 7 CLAB infections per month. This is translated to 6.6 incidents per 1,000 line days. However, this 6.6 incident per 1,000 line days have been reduced to 3.32 incidents per 1,000 line days in 2012. New Zealand launched a project called Target Zero Club, which aims to reduce further the CLAB rates. So the baseline they reported was 3.32 during 2012. But in 2013, they recorded about 0.28 CLAB incidents per 1,000 line days, which resulted to about a 90% decrease of CLAB rates in New Zealand. Evidence-based measures in CLABSI prevention. These are the measures endorsed by the Society of Healthcare Epidemiology America, or SHEA, and the IDA, or the Infectious Diseases Society of America. There are a lot of measures, but I'm going to discuss about the few ones. M stands for moderate evidence, and H stands for high evidence. Before any procedures, it is important to educate healthcare workers with regards to the management, insertion, care, and removal of central line catheters. Different strategies can be used, like seminars, trainings, and proficiency exams to ensure the highest quality of care provided to the patients. Next, bathing ICU patients over 2 months old with a chlorhexidine preparation. Chlorhexidine has been proven to clean thoroughly and thus reducing infection. During catheterization, we should have a process to ensure adherence to infection control practices, for example, a checklist. Next, hand hygiene before insertion or manipulation. WHO's hand hygiene guidelines is the single most important practice to reduce infection. Avoid using femoral vein for central venous access. Using an all-inclusive catheter kit. A catheter kit which has the essentials is really important to maintain the highest standard of care. Maximum sterile barrier precaution. Maximum sterile barrier precaution means that the healthcare worker should don a sterile gown, sterile gloves, a face mask, and a hair cap. And the patient should be covered by a sterile drape to ensure the maximum sterile barrier precaution. Alcoholic chlorhexidine antiseptic for skin preparation. Before catheter insertion, the doctor should put a alcoholic chlorhexidine solution in order to clean the insertion site. This should be allowed to air dry. Lastly, using ultrasound guidance for internal jugular catheterization. The doctors could use a ultrasound guidance in order to ensure that the catheter is inserted precisely, thus reducing the risk for reinsertion. After catheter insertion, replace administration sets not used for blood products, or lipids at intervals longer than 96 hours. Constant replacement of these catheters would increase the risk for infection. In disinfection of catheter hubs, needles, connectors, and injection ports before catheter access. So before nurses and allied health professionals should get blood or insert medications in the catheter hub, it should always be cleaned to reduce the risk for infection. Regular changing of transparent and gauze dressing. So this is an example of a transparent dressing used over the catheter insertion site. Then, removal of non-essential catheters. So doctors should always assess if the catheter is still essential, and if it's not, the catheter should be removed as soon as possible. to reduce the risk of infection. Appropriate nurse-patient ratio, use of antimicrobial ointments for hemodialysis catheter insertion sites. So hemodialysis patients are more prone to infection, so they should use antimicrobial ointments, but this is not recommended for non-hemodialysis patients because antimicrobial ointments have no antifungal activity, which would increase the risk for fungal infection. And lastly, perform surveillance for CLABSI in ICU and non-ICU setting. Having a surveillance for CLABSI rates is important because this would allow the hospital administration to create new strategies to battle CLABSI. Centers for Disease Control and Prevention also provides their own evidence-based measures to prevent CLABSI. So both the guidelines set by SHEA and the CDC have their similarities and differences. I'm going to discuss only a few of them. Training, education, and staffing. The selection of catheter sites. Both SHEA and CDC does not recommend the use of femoral site, but CDC adds that we should not use the subclavian sites in patients suffering from end-stage renal disease and hemodialysis patient. This is because the use of the subclavian site would increase the risk for subclavian vein stenosis, which is the thickening of the subclavian vein wall due to the increased venous blood inflow. Hand hygiene as a septic technique, maximal sterile barrier precautions, and skin preparations, all the same with the SHEA standards. Catheter site dressing regimens. The CDC adds that the catheter site should not be submerged underwater, and if showering would be permitted only when there is a sterile barrier that is impermeable from water over the catheter site. Next, patient cleansing, and lastly, replacement of the CVCs. So CDC adds that the administration set used for blood products should be replaced in intervals not greater than 24 hours. After blood transfusion using a central line catheter, the administration set should be replaced with a new. New Zealand standards. New Zealand has a lot of non-government and government bodies that promote standards for CLABSI. So first is IVNNZ, or Intravenous Nurses New Zealand. It was founded in 1993 as a voluntary organization for nurses, midwives, and allied health professionals. And since March 30, 2012, they have been releasing standards and guidelines for CAVD management, which aims to have excellence in CVAD management by providing trainings, seminars, and conferences to update the education of the nurses. Also, district health boards, or DHB, have these professional accountability, which ensures that the nurses are up to par with the competencies for entry to the register of comprehensive nurses. So, for example, Canterbury DHB have this certification, a level 2 certification for central venous access devices, or CVAD. This is a 3-year recertification with a prerequisite initial intravenous therapy certification level 1. Every 3 years, this is renewed, and education is provided about the physiology of the human body, where the veins are located, the central veins are located, the complications when inserting these central venous access devices, maintenance bundles, choosing CVA sites or central venous access sites, removal of the catheters, and the healthcare infection management. Lastly, multi-choice theory test with a 100% passing rate must be done, and a practical skill assessment in order to ensure the highest quality of education.
Centerline evidence-based prevention and control standard. In the United States, there are more than 15 million people each and every year they get affected because of centerline infection, and CDC government and SHEA organization, they made a separate guidelines for this in 2011. So these are the guidelines. The first one is use sterile gauze or a sterile transparent dressing to cover the catheter site. These are the sterile gauze which they are using to cover the dressing, and this is the transparent sterile gauze which they are using for 7 days dressing, and this we have to use only 2 days. And if the site is bleeding or oozing, use a gauze based dressing until the problem gets resolved. If the catheter dressing site is bleeding or oozing, we have to change the dressing immediately, or else it's easy to get infection. Replace the catheter site dressing immediately if the dressing becomes wet or loose or visibility soil. The important thing is we always have to check the dressing. It should not become wet. If it is wet, it's easy to get infection. So we must change the dressing immediately. Do not use any antibiotic cream on the insertion site, especially on the centerline catheter. We are not allowed to use any antibiotic, because when they are using the next antibiotic injection, it becomes antibiotic resistant. So it may lead to fungal infection also easily. So we have to avoid. Guidelines used in New Zealand and internationally to prevent and control the catheter related infection. The first point is replace the catheter gauze dressing every 2 days. If each and every days we have to make sure the catheter dressing is perfect or not, or else we have to change the dressing each and every 2 days once. And if the dressing is transparent dressing, we have to change 7 days once, because the transparent dressing has more protection for the infection compared to the gauze dressing. So make sure the catheter site is comfortable with the catheter material, because if the catheter material is not comfortable with the catheter site, it may lead to infection. So these are the evidence-based recommended practice and prevention according to the CDC guidelines, which the performance of controlling and prevention has improved after the survey. So after they complete this evidence-based survey, the standard method has increased compared to before. It happened in 2011 according to CDC government. CDC full form stands for Center for Disease Control. Evidence-based infection prevention and control standards and guidelines used internationally. There was a research in 2015, investigation about CLABSI started between June and October. This research is about how to improve the CLABSI standard and controlling the infection. There are more than 95 countries provided 3,407 individual response. More than 95 countries has participated in this research, including doctors and nurses. From each and every country they got an individual response, more than 3,407. So this study has identified areas for improvements in CLABSI prevention practice linked to CL insertion and maintenance. And this study is very helpful to improve the quality of care, also prevent the infection, and especially when it comes to centerline inserting, also how to maintain without infection. Survey used in New Zealand and across Australian states. There are 2 published guidelines from CDC, including the Center for Disease Control and Prevention, and these surveys performed because of reducing the nosocomial infection. And these surveys performed more than 27 states in Australia, and in New Zealand pediatric units. Cross survey sectional survey was performed across Australia and New Zealand neonatal units in 2012. 70% at medical management and 59% on nursing management survey were completed, and from this survey they got a prevention and control, how to improve the neonatal centerline associated infection, also from the medical management for adults and all other age people, how to prevent the infection and infection maintenance. And There were guidelines for CVC maintenance, and for 18 out of 19 there were guidelines for insertion. This happened after the survey. Around 18 guidelines for the maintenance and the 19 guidelines for the insertion center line. Thank you.